Cosi Talks Live. We are going to get started tonight. So, for those of you who are watching the replay, first of all, thank you. You guys are um, always wonderful about leaving comments in the section that you're watching the replay. Sorry, I'm having a little tongue twister night tonight. I can't speak directly tonight. Anyway, so for those of you watching the replay, thank you. Please give me a shout out in the comments section and just say you're watching the replay. And if you have any questions that you want me to answer, go ahead and put those in the comments section as well. I do go back and check the shows after they've closed down to see any questions are left behind. So I think I need a sip of my coffee. Yeah. Cheers to you guys. All right. Compadre, what's going on, man? All right, guys, I'm going to give you guys a couple of minutes to jump on board this evening. I see some people jumping on board. So as you come on board, guys, don't be shy. Let me know who you are, where you're from, and what's in your coffee mug, especially if this is your first time joining the Cosi Talk Show. All right, guys, let's see. Oh, we've already got one question coming up from Scott. Hey there, you got the copy there from my left AK. Okay, and you're watching me from the YouTube channel. So guys, just so you know, I do broadcast to both my Facebook Cosi Talks and my YouTube Cosi Talks channel. So you can watch me from both live streams there in case it's a little easier to find me on the YouTube channel. Hey there, David, looking for those shoes. You are so funny. I know I started running with those shoes 2 days ago, man. It's always nice to get a nice new pair of running shoes and start breaking those in. And yeah, those are definitely bright. You can definitely see me coming from a mile ahead with those shoes. We got Steven and Jayville here for the beer. Well, you have something more interesting. I got my plain old decaf right here. Come on, what's up going on, comadre? We got Emily on board. She's got frozen hot chocolate with a shot of espresso from Dunkin' in Central PA. Nice, Emily. Very nice. We've got Diane coming in from Canada. It's Brett the cool kid. There we go. Okay, Brett, thank you for letting me know who you are. We got Drew on board. Oh, absolutely. My pleasure, Drew. And we're going to be talking a little bit more about some of the questions that you asked today or this past week because they were really, really good questions. So, guys, let's see. We got Richard drinking his Arabica. I don't even know how you pronounce that. Arabica coffee from Mission, Texas. That's the good stuff there, Richard. All right. And all right, numbers are climbing up quickly tonight. Okay, guys, awesome. So we'll go ahead and get started. For those of you who are joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for a little over 20 years. That's a really long time. And I'm really excited, guys. So last week, I was able to get back into the clinic. I had to take a bit of a hiatus for a few months as I was taking care of my father before he passed away. And last week, I was able to go to one of my favorite clinics here in the Tampa St. Pete area, the St. Petersburg Limb Embrace Clinic run by Gina and Mike, two of my favorite folks to hang out with. And I got to see some really lovely people. So guys, if you're on my Instagram and Facebook, go to the reels and the story. And I posted just a little reel on some of the patients I was seeing that day, a couple of bilaterals and one out of state patient, and just so wonderful to be back in the clinic again. So just that's what I love to do. So let's see. Andrea says, no text tonight. I know, Andrea, that's my fault. I did not send out the reminder text tonight, and I do apologize. She says, glad you met Beth. Yes, we've gone biking, lousy internet tonight, so may not be here long country living. Oh, that's okay, Andrea. I'm always love it when you join in. So guys, let me just go ahead and take this time. For those of you, especially who are new to the show, with the exception of tonight, I usually send out a text reminder to my viewers. So if you would like to be put on that texting service, just text Cosi Talks, all caps, one word, to that number, and you will start receiving my text messages. Like I said, tonight, I apologize. I was running a little late tonight, so I wasn't able to get that reminder text out. But this is really cool because also when I do my giveaways with my sponsors and I have anything special coming up, you guys are the first to know, those of you who are signed up for the texting service. So if you haven't already done so, go ahead and do it. Hey, Harsh. Oh man, glad you're here, Harsh. And we got Tom on board watching from the Maple Syrup Shack, sipping on fresh maple syrup. Okay, that's awesome. Like, are we talking about like the little spigot that goes right in the tree and you just tap the tree for the syrup kind of thing, Tom? Because That's just kind of awesome. We got Harsh coming in from Richmond, Virginia. Cheers to you as well, Harsh. Okay, guys. So this week, not a whole lot of questions. So if those of you who have questions, go ahead and put them into the comment section. I was having a lovely conversation. I know, right, Andrea? I was having a lovely conversation with one of my newer viewers. He had a lot of really great questions, and I'm going to go ahead. Ooh, let me set this up while I can. Sorry, guys. I am setting up my strong body program videos because I'm going to be sharing with you one of the videos tonight. Sorry, logging in. All right. So this first part of the question, this individual said that he bought one of my strong body subscriptions, and he was asking what exercises are good for strengthening the glutes. And y'all know I love my strengthening exercises for the glutes, right? Tom, that would be so awesome. That would be so awesome. I'd have to hide it from my kids, though. I'd have to put it up in the mom drawer that the kids aren't allowed to get into. So, anyways, guys, when it comes to strengthening and improving your gait pattern, this is probably the most common question I get is, what should I strengthen? How should I do it? What should I focus on? Okay. Glutes, if I had to pick one muscle group of the entire human body, I would say the glutes. And this goes for my A case, my B case, my unilaterals, and my bilateral amputees across the board. And this is all even for my two-legged folks that have back pain and all sorts of hip pain and knee pain issues. Glute strengthening is, I think, a lot of where a lot of the key problems begin and can be solved right there. Okay. So for this particular individual, um, he has been working with a physical therapist, but is not quite independent with his gait training yet. So usually when it comes to the glute strengthening, guys, I do start off with the beginner exercises, even with some of my higher functioning folks. And the reason for this is usually when people start walking, right? If they don't focus on strengthening a particular muscle group, right? They may not be recruiting all the muscle fibers, right? Our brains are kind of lazy. Our bodies are kind of lazy. Our bodies and brain are just going to put forth the minimal amount of effort we need to complete a task, right? So that's what strengthening a muscle is all about, is you're loading that muscle more than what it's used to doing to force it to recruit more muscle fibers. Okay. So like I said, oftentimes, even with my folks who are athletes, right? I've had some of my runners that I've had to put on the phase 1 glute exercises. So guys, what am I talking about with phase 1? I have a strong body program which is comprises of 150 video exercises for above the knee and below the knee amputees. It's head to toe strengthening and conditioning. That's basically what it is. And it comes with 2 books that have all the exercises in here. Many of you have been purchasing the program and the books. I even have some prosthetist clinics that have been purchasing the program and giving it out to their patients. I'm really excited. So I am going to go ahead and I'm going to share my screen so I can show you guys what are some of the glute exercises that I like to do for my patients that are from my strong body program. So let me see if I can do this without messing it up. All right, we're going to share the screen this way. Okay. All right. So hopefully you are seeing the main page of my strong body program. That's my amazing Avengers team right there. Those are my beautiful models that I have. So let's just go up here to the above the knee. So if you have my program, when you log into the account, this is the screen you're going to see. Okay. So you can either go to the table of contents and get all of your exercises that way, right? And all the exercises are here fully linked. Or you can use a drop-down menu. I personally like the drop-down menu. So I'm going to go to, and obviously you can see arms, legs, core, balance, and flexibility. All right, so we're going to go to legs and we're going to go to phase 1. So with each body part, guys, I've divided it up into phases 1, 2, and 3 for legs, core, and balance. And the reason for this is because I find that even with my own patients, some of my patients might be phase 1 with legs, but they might be phase 3 with arms and phase 2 with core. Okay. So this way you can kind of mix and match according to what your needs are. All right. So let's take a look at the phase 1. Okay. So here are some of the glute exercises. Glute sets Okay. That's like the first one. This is the first one that you do when you are coming out of the OR and that physical therapist is right in your face saying good morning to you. I know you just love it when we do that. Right. So the glute sets and basically with the glute sets, it's really easy. You can do this in sitting position, like you see Rob in my model. You can do it in the lying down position. And what you're doing is basically you're squeezing your glutes, you're squeezing your bum together. And there's a whole video on this. So when you click on these, you get, sorry, my computer is running a smidge slow today. You get a full video where I explain everything about this. Okay. But let's go back. Let's go back from real quick. Okay. So in the phase one, we have the basic bridges. A lot of you guys have seen me and talk about the bridging, and I show you here how to do it without the prosthesis and also with the prosthesis as well. Okay. There are the hamstring sets, which technically are not your glutes, but this is also something that's really connected close by the glutes and should also be done, right? The other part of it is right here, straight leg raise prone, meaning you're lying on your belly and you're doing the straight leg raise. That is majorly targeting those glute muscles right there. Okay, so that's one right there. So those are a couple of the good ones on phase one alone. And it doesn't seem like a lot, but guys, when you start doing these, you're going to start to feel them. The tennis ball circles, these are also really great, mainly for your glute medius, those stabilizer pelvic muscles. Okay. And then the cool thing, which I like about my program, is as you get stronger, the exercises progress with you. So for example, the booty crossovers, right? Another great one for the gluteus right there, the glutes right there. Whoops, clicked on it on accident. Let me go back. Okay, here's how you take the bridging and you progress the bridging right here. So once you're able to do the basic bridges from phase one, I usually recommend folks to go up to the kick it up a notch bridge. You can also start incorporating lunges, right? And the squats. And yes, my above the knee amputees can do squats. Okay, did that go through, guys? Did that go through? Would you guys, because when I'm sharing my screen, I can't see comments or anything like that. So if you guys don't mind giving me a thumbs up if you heard all of that, or was it just like dead airspace right there? I'll take a sip of my coffee while I'm waiting. Joan! Joan, you have been on my list of people to call for weeks. Okay, thank you guys. So all of you guys heard that. Okay, awesome. All right, let me see a couple of comments that came in while I was jibber jabbering on the other side. Hey there, Marianne. Let's see. Patricia asks, I'm a left AK. I've been using forearm crutches. I'm trying to get down to one forearm crutch. I'm using the one forearm crutch on my dominant side. When I use it, I'm pressing so hard the crutch that it's hurting my hand. What exercises do I do not to lean so hard on that side? So Patricia, this is a great question. And I kind of sort of answered it. I see that you said that down there, but not really. So if you are a left AK, left-sided amputee, to get the most support from a one-handed device, yes, you will be holding it on your right hand. Okay. And I know some people are just like, well, that doesn't make sense. The physics works out, guys. Whatever your weak side is, you hold the cane or the crutch on the opposite hand. Okay. Now, if you're leaning too much into that crutch, Patricia, it might mean that you're not quite ready for that part yet. Okay. But it also means that you need to work on the weight shifting. So let me just explain a little bit about how I progress somebody from a two-handed device to a one-handed device. Okay. When I'm working with a two-handed person, or excuse me, when we are working with a two-handed device, so let's say I'm teaching someone to use crutches, forearm crutches, axillary crutches, a walker, right? I'm still doing a lot of work in the parallel bars, okay? I'm doing a lot of weight shifting exercises in the parallel bars. And Patricia, I think you've been working on those as well with the weight shifting exercises, right? Now, when I feel that a person is ready to start working with a one-handed device, I actually take them back to the weight shifting exercises. Okay, so it's kind of almost like a 2 steps forward, 1 step back. Okay, and the reason is because the body has to get used to that one-handed feeling, right, in a controlled manner. So if I just put someone on a cane, if I take out their walker and I just give them a cane and I start gait training with them, they're going to be all over the place, even if they are strong enough and ready for it. Okay, so Patricia, that might be what's happening. Some people are just like, okay, I've got two crutches. I'm zipping up and down the other all over the place. Let me just put one crutch to the side and start going with one and just muscle through it. Yeah, it's going to be a lot harder and very frustrating to do that. And then you're going to wonder, well, is it because I'm ready or because I'm just doing something wrong? Chances are you just got to back it up just a little bit, Patricia. So I learned that years ago with my patients that when I'm progressing my amputee patients, right, to one handed, I take them back to the weight shifting exercises and I have them practice it with the one hand. Okay. So some of you have watched some of my foundational exercise programs that I have. So you see that I have my template on how I progress my patients, and a lot of it, a lot of early foundational work with the weight shifting in all the different directions. I do a lot of single limb stance, meaning they'll um, raising their one leg up, doing the tennis ball circles. That's another really good one for you too, Patricia. So the tennis ball circles are in the phase one legs section. And actually, I'm gonna shift just a bit here because I think it's good. Okay. So those of you who have my book, I have the above the knee book right now on page 39. So it's actually pages 38 pages 38 through 40, I show you how to do the tennis ball exercise, okay? And I'll put this up close. So as you can see, the model is holding the tennis ball under his sound foot, right? So he's putting all of his weight into the prosthetic side. Okay, so Patricia, this is a really good one for you because if you're putting all of your weight into the dominant side, it means you're not putting enough weight into your prosthetic side. And this is a fantastic exercise to get yourself to start putting weight into that prosthetic side. Now, he's doing it without holding on to, he's just holding on to a chair, but that was for the sake of the picture. I always recommend that you do this at first, holding on with two hands to the kitchen counters or the parallel bars, right? And then when you're ready and you're able to do that in a strong way, then go ahead and just lift one hand and start practicing it with the one hand. Okay. So I hope that helps, Patricia. Andrea asks, what is the best way to know if a liner has become too loose due to weight loss and medical issues? Rehab patient wants to hop back up on his AK, not since, 22, in November of 22. And I am concerned the liner is too loose. Any tips? I know it is socks, 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 but not sure how to judge the liner. Prosthetist is over 2 hours away, so cannot visit. So a couple of things, Andrea. First of all, if it's a liner, the liner is supposed to go directly on the skin. So if the liner is too loose, you have to get a new liner, right? You can't fix that problem with socks. If his socket is too loose, then yes, you can add socks outside of the liner. I hope that makes sense. And I forgot to raid the closet of my favorite prosthetist so I could bring in some stuff and show you guys some of these things. Okay, so mental note, raid the prosthetist closet and bring home some toys. Okay, so if the liner is too loose, you're going to know because it's too easy to put on. That's the first sign right there. And I joke around with my patients, especially my female patients. I'm like, if it doesn't take a little effort to put your liner on the same way that it takes a little effort to put stockings on for ladies, right? Then your liner is probably getting a little bit loose. Okay. The other way to know if the liner is too loose is if the person is having skin issues, right? That liner should be fitting like a glove. It should be really, really snug on the individual. Okay. So if it's a loose and there's an air pocket in there, there's going to be a shearing of the liner with the skin, and you're going to start to see redness. You're going to start to see increased sweating, right? Because there's room in there and there's air pockets. So you're going to see the sweating forming right there. You might even see a little puddle of sweat on the bottom of the liner when the person takes the liner off. So those are the hints that liner is too big. And if the liner is too big, there's no hack for fixing that. That has to be replaced. Unfortunately, they have to go back to the prosthetist, right? If a shrinker is too loose, then you can put sew a seam into it, like we talked about last week. If a socket is too loose, then you can add socks. But once a liner is too loose because of weight loss or because they're just stretched out, that's it. Okay. And the thing is, if you put socks directly onto the skin and then put the liner on, number one, you're going to have a lot of skin problems because that's not how it's meant to be worn. And the liner is going to do no good to you because the liner is meant to go directly onto the skin. So yeah, sorry, Andrea. He's gonna have to. Sounds like your patient's gonna have to go back and go back to that prosthetist. Emily says, definitely need a new shrinker. Either it's too big now or stretched out or both because I got into bed a few days ago and it literally slid off my leg. Yep, that's a good sign right there. My compression socks before surgery were 40 compression. And now my shrinker's only 20 to 30 millimeters of compression. Okay, so you had a higher, I think because of the lymphedema that you mentioned last week, Emily. So that's probably why you had a bit of a higher compression on your stocking. Yeah. Okay. All right, let's keep going. Oh. So Emily says, struggling the most with my quadriceps exercises right now. They're pretty weak. I definitely felt it on Friday at PT, but my hamstrings are okay. Okay, so let me just show you because guys, I've got my strong body program up. So do y'all mind if I just keep sharing some of the exercises from the program? And that way, those of you who have the program, you can kind of start getting ideas as to where to look in the program. And then those of you who don't have the program, you get a sneak peek. Okay. Okay, so for the quad exercise, I'm going to go back to, and you know what, let's do, well, yeah, obviously it's going to be below the knee. Okay, so it goes back to phase 1 legs. There are my quad sets right there. Okay. So guys, let me see if I can play back the video. So among the first exercises I do with patients when they are literally like right out of the OR, the glute sets, which is the one I showed you previously, and the quad sets. And guys, quad sets are some of my favorite exercises to do when a person is right out of surgery. And this goes for my knee replacement patients, my hip replacement patients, people who have had fractured femurs, people who've had their leg just basically chewed up and put back together again with glue and duct tape. Quad sets are my first favorite exercise to do. It's a simple exercise, and especially people who are having a lot of that post-op pain. This is a very easy exercise to do for them. And on top of that, it helps start activating that quad muscle to use as a muscle pump to pump out the inflammation. So let me just see if I can press play and hopefully you guys can hear the playback. These exercises are called the quad sets, and they're some of my favorite exercises to do when folks are starting to get their strength back. Quads are the top part of your thigh, and whenever you have any kind of surgery, these muscles tend to get really swollen and inflamed, causing a lot of pain. So this exercise is not only good for exercising and getting things strong, but also for helping to push out that inflammation. So here's how I like to try. I usually like to start out with the sound leg first. I'm going to put my fingers underneath Damon's knee, and I'm going to tell him, push down into my fingers. Go ahead, push down. And as you can see, he's tightening up his quad muscle really nicely. And then relax the muscle. Okay, tighten it up, hold it for a count of 5, 2, 3, 4, 5, and then slowly release the contraction. Once you feel like you've got a good grip of it here, we're going to go ahead and do it on this side. I always like to do the exercises with and without the prosthesis. Okay. So once again, he's going to push down his knee and tighten up his quad muscle. Okay.
Move forward.
That's fine. Yep.
Okay.
Let's move it forward. All right. So you can see that nice quad tightening up. All right. So he's going to push down and tighten up that muscle and hold it for a count of 5. And then relax the contraction. Push down, contract, and hold. And then relax. And as you can see, as the trembling, it's really working that quad muscle. What I like about this exercise is not just about how strong your contraction is, but also how you can control the muscle as it's contracting. All right, go do your repetitions. Okay. Haha, 2 times in a row. Yay, go me. Okay, so as you can see, I really like the quad exercise. Now, what's really interesting, and I'm just having a memory, when we were filming this, I mean, you guys have seen Damon. Damon's been on, he is no stranger to my show. He is a friend, and I can't be thankful enough that he was a part of this program. And he is now one of my running buddies. But when we were doing this show, he was struggling with this exercise. We actually had to practice it a couple of times off screen, off camera, before we filmed it because he was having trouble activating that quad muscle. And as I talked to him, he said, yeah, I never really received physical therapy after my motorcycle accident. right? And he walks beautifully. Like you see Damon, and if he's wearing a pair of pants, you cannot tell he's an amputee. He has a beautiful gait pattern, and you can see, he's a pretty good shape guy. But he never had that physical therapy to rehabilitate that muscle. And if you guys looked closely at that video, there's a difference in his quad size. Like you can see in his sound size in his sound side, when he was contracting that quad muscle, you could see the definition in the quad muscle. But when he was contracting it on the side with his prosthesis, you're not seeing a whole lot of definition there. There's still a lot of weakness in that quad muscle, right? So the reason why I'm kind of saying that is, y'all know that's my soapbox, is how much I advocate the need for physical therapy. It should be just as logical as having pain medication, as having a prosthetist after amputation. You need physical therapy. One of the things that was holding Damon back for years was that he wasn't able to run. And the reason he couldn't figure out why he couldn't run, it was because, well, there was still a lot of residual weakness in his limb that needed to be addressed, right? So I gave him a lot of these exercises to do, and now he's running. He's getting his distance, and he's starting to run again. So whenever I hear someone say, well, I didn't need physical therapy, or my patient doesn't need physical therapy, they're walking fine, I just go, okay, but you know what? Not having that physical therapy is either going to lead down the line to either injuries, chronic injuries, or it could prevent them from doing something that they really love to do, like running. Okay, that's my little PSA for tonight on physical therapy. So Emily, when it comes to doing these quad exercises, I like that exercise because your brain can focus just on that muscle group. Okay. And one of the patients I was working with this past week, bilateral patient, I kept telling him, you need to focus on this one muscle group, because of the fact that it's so weak that the other muscle groups want to compensate and take up the slack. And you got to say, no, they need to wait their turn. You need to isolate that weak muscle group and allow it to really start contracting and taking the reins there. Okay. And again, it's easy because since it's right in front of you, you're getting that visual feedback by seeing that muscle contract. And in some cases, it might just do a little bit of a tremble, like a jelly, especially when it's like fresh out of the OR, right? You might just see a little bit of a trembling, and that's fine. I tell people, you know what? That trembling means that there's a contraction happening there, right? And you just have to let it, be patient with it, and let it get a little bit stronger over time. Okay. And then when you get to be really good, you can slowly see it contract and slowly see it relax. It's not just like an on-off switch. You want to see it slowly contract, slowly relax. Hey, there's my girl, Kristen. So I got to give a shout out to my girl, Kristen. She is the amazing videographer, and she put together that entire website program that you just saw, guys. So all that beautiful cinematography that you're seeing right there, the amazing graphics, that is my girl, Kristen, right there. Let's see. Oh, Andrea says, patient is refusing to wear the shrinker, and that was my recommendation. All he wants to do is throw the leg on and go. Driving me crazy. I want to make sure there are no skin or safety issues. And Andrea, you just got to keep on it. You know how it is. I've had those patients that are just so excited, so motivated to get going that they just want to bypass all the steps and just get to the fun walking part. And then it runs into problems down the line. So I always hate to be like the party pooper, and telling my patients, no, we can't do that just yet because we don't want to shred your skin to pieces, because then we're really going to be set back. So hopefully you can talk some little sense back into your patient. Let's see. Joan says, can I ask a question about a callus on my residual limb? Yes. I am a BK and the callus is on the front of my tibia, and now it has cracked, putting me back on crutches. But what can I do to speed up the healing of the cut and get rid of this callus? So Joan, especially if you're not diabetic, open to air. Honestly, it's open to air to let that cut heal. Maybe just a touch of Neosporin, little bacitracin on there. Once it's completely healed, then I would say working on that callus. And I'm kind of old fashioned when it comes to working on the callus. I like the warm water soak to soften up that callus. And then depending on how hard that callus is, and again, you don't want to be too aggressive, because if you're too aggressive, then you're going to open up your skin and you're going to have a problem. If it's like a soft callus, like just get a terry cloth with the warm water and just kind of slough off some of that skin while it's nice and warm, and then put lotion on it and moisturize it. And again, this is after the cut is healed. You don't want to do moisturizer and all that kind of stuff when you have an open wound there. So once it's closed, moisturizing it, right? And then using that terry cloth on occasion, when you have somebody who has a really, really tough callus, you can use a pumice stone that's not too rough. And again, warm water, get the skin softened up just a little bit, and then just gentle rubbing to start rubbing some of that callus off, and then putting lotion on it, okay, to soften it up. The big thing, Joan, is you got to find out what is causing that callus. And I know I say that all the time, but it really just goes back to that. What is going on in that socket that is putting pressure and rubbing up against your tibia, causing that callus? Because that's the only reason a callus or a blister will form, is that there is shearing going on right there. And the thing is, with our tibia, our below the knee patients, right, that tibia tends to stick out. And the longer you are a BK, a below the knee amputee, the more those muscles will atrophy, the more that tibia bone will start to stick out, right? So you have to be creative sometimes as a prosthetist when you're fitting your patient. I know that Ronnie, he's one of my favorite prosthetists. He's been on the show several times, and he's an above the knee amputee himself. You know, he says that when he is putting a liner and measuring for a liner, he makes sure that he puts the soft tissue where it should be, right, when he's measuring for the liner and when he's putting the liner on. So he might bring up that soft tissue to help kind of pad the end of that tibia and then put the liner on. Okay, so even little things like that, to see how that's going. The other thing to think about, Joan, is this is where, if your prosthetist has really tried everything, this is where a custom liner might be in order. And the mom brain moment, custom polyurethane. Those liners tend to work really nicely for the below the knee patients who have that bony tibia, and shuttling away the pressure from those pressure point areas, pressure sensitive areas. Yes, quads are super important to the AKs. And guys, even with my AKs, depending on how long or short their residual limb is, I will still have them try to activate those quad muscles, right? If they're there, we try to work on them. Let's see, Drew says, add that to my problems. My prosthetist ignored me for months, telling me, okay, my liner to be loose. It slides on without any resistance, refuses to replace it. Sad situation. No, yeah. If your liner just easily slides on, it's too loose. It really is. And as pain in the neck as these liners can be to put on, it should be a pain in the neck, right? It should take a little bit of elbow grease to get that liner on, guys. I am a stickler with my patients, those people who have been my patients and have had me teach them the beginning, prosthesis 101, and they learn how to put on their prosthesis properly. I'm a big stickler for putting that liner on properly, turning it inside out all the way every single time, making sure the center of that liner goes right, that cup goes right on the end of that residual limb, and making sure it gets rolled up nicely that way. So yeah. And usually kind of the rule of thumb is I tell people, your prosthetist should be giving you 2 liners at a time. Okay. And one should be drying in your bathroom, and while you're wearing the other one. Your liner needs to be cleaned once every 24 hours. And it takes a little time for these guys to dry, and they need to air dry. Don't dry it with a towel, or otherwise all that terry lint will get stuck on it. I had a patient that happened to it. Ooh, that was not good. Okay, so you need 2 liners, one that's being washed and dried and the other one that's being worn. And then just depending on the liner and depending on your activity level, you can replace it anywhere from 1. I've had some, I forget which is the liner that some people say they only have to use it once a year, replace it once a year. But typically it's every 6 months you need to get your liners replaced, typically. Yeah, liners should not be loose. So Emily says, I think I overcompensate for my weak quads and end up using my hip abductors instead. I really have to focus on trying to use my quads and not my hip abductors. So yes, and usually what I say, and again, Emily, I haven't seen you, so I don't know, but what happens a lot, especially for my women, right, when there's weakness in the quads and the hamstrings, the tensor fascia lata, right? Fancy name, right? Tensor fascia lata is a little tiny muscle about yay big. And it is, let me see if I can show you where it is. Come here, Bob. So it's actually starts here, the side of the hip, and it just kind of goes over the hip here, and it goes into, it kind of melds into the IT band, the iliotibial band. Okay, so even though it goes from here all the way down to here below the knee, right, the actual part of the muscle is just a tiny, tiny little slip of it. right? And when you have weakness in your glutes, when you have weakness in your hamstrings and quads, like I said, especially in my female patients, the TFL, the tensor fasciae lata, tends to take up a lot of that slack. And for a tiny little muscle, that's asking a little too much. And that's where you hear people having IT band syndrome, where they have problems with their IT band and they get the shooting pain down the side of their leg. That's because that's what's going on. So, yes, strengthening of the quads and the hamstrings and the glutes and getting everything to work together is how you help solve that problem. So good on you, Emily, that you're recognizing this. And again, it's putting in the steps. If you start to strengthen those quads, the nice thing is they strengthen pretty quickly. It's kind of cool to see how fast that they can get strong. Oh, thank you, Drew. I appreciate that. And guys, those of you who have the Strong Body program and are going to physical therapy, take the Strong Body program with you. Okay. And I'm not doing that because I want to show off to my fellow PTs. Physical therapists, we use software programs in our clinics, right? And those of us who work home health, same thing. We have software programs where we can download exercises so that we can give them to our patients to do at home, right? Y'all know those packets of paper. There's nothing like that for amputees. There's not. Okay, that's one of the reasons I created this program. So for those of you who have this program and are being seen by a physical therapist, show this to your physical therapist. Your physical therapist is going to be like, oh my gosh, this is great. Thank you. Because then they can go through and tell you, I want you to do this exercise, and this exercise. And you're not ready for this one just yet. Okay. So it's all right there. Hey there, Ernesto. Made it live this time. VA in San Diego, California, checking it. Oh, yeah. Thank you for coming on board, Ernest. Let's see. Yes. So I would say, Joan, just warm water and just soak it a little bit and just see what happens to that callus. If it's really still not, if you're not seeing any progress with it, then I would say go see the dermatologist and see what they can recommend for the callus. But again, just working it off little by little. If it's a softer callus, then you can get rid of it pretty quickly with moisturizer and just little gentle rubbing with that terry cloth. Yeah, I know some of you who have your prosthetist said that they are a drive away. Yeah. Hey, there's Tom. There's my other Tom. Oh, Tom Allred here. He says, I'm relearning the value of slow, steady pinpoint exercise to regain strength without causing new or additional injury. Okay. And guys, the older I am as a therapist, and I'm getting kind of up there nowadays, right? I really value doing things the right way. As a young therapist and just as a young human being, you tend to want to rush things a lot and you want to see your patient go, 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 go. And then you realize because I didn't lay certain foundation correctly, I got to go back and do it again, right? My dad used to say, you don't have time to do it the first time, but there's always time to do it the second time, right? So when I see a weakness, a muscle weakness in a person, in one of my patients, I say, okay, let's really take the time to focus on this weakness and work it out properly and allow the brain to really focus in on it. All right. It's not the thicker, squishier liner, Joan. You're thinking of the gel liner, which the gel liner, I call it like the Cadillac of the liners because it's like a nice, cushy ride. And it's great. I love it for my older folks, especially those who have more fragile skin. But it's not really meant for like high active folks. Like it's meant for just a nice, cushy ride. Some people use it and they love it. The silicone is kind of like the standard. Usually most of my people have some flavor of silicone liner. And again, those folks who have sensitive skin, grafting on their residual limb, or they have a very bony prominence on the residual limb, or they have a really tough fit, then they might use that custom polyurethane liner. My pleasure, Richard. Thank you for joining. Hey there, Beth. Thank you for coming on board. Gregory asks, what are my thoughts on the power knee? Interesting that you should ask that, Gregory. So I actually got to play around with 2 power knees this past week. So the power knee, and again, guys, I am still learning about the power knee, so I am not going to give any information that I'm not sure about, okay? It's a knee made by Oser. And I don't even know if they necessarily call it a microprocessor knee. I don't think they even classify it as a microprocessor knee. But for the sake of just simplicity, it is a flavor of microprocessor knee. I think I can say that, right? So it's actually been around for like 10 years. It's been around for quite some time now, but it hasn't really, you haven't seen it a whole lot. You're starting to see it pop up more. I got to see it for the first time in November of 2022 when I went to the California O&P conference, right? I really like it. I gotta say, I really like the power knee. I especially like it for the bilateral above knee amputees. Okay. So, guys, the little reel, and I'm no expert at reels, the little reel that I posted today on my Instagram and Facebook channels, you can see it in my stories section. You're going to see a gentleman who's a bilateral above the knee patient who's walking up and down the bars. He's using the power knees. I will say the first thing that got my attention about these power knees is when I saw him stand up from the chair. And when he stood up, he just did this. That's it. Like he stood up like that. And those of you who are on my bilateral AKs, you're going, oh, I get her. I get what she's trying to say. If you've ever seen a bilateral above the knee amputee get up from a chair, it is hard work. It is hard work. Okay. And for the mechanical knees, it takes hard work and it takes a lot of time. Okay. So I am just that part alone, it kind of does the work for you and it boosts. And, there's a contact I have with Oser and he's been trying to educate me on the power knee. And I just need to sit there and learn it. But it does more of the work for you. Okay. And I will say two things because I know there might be some people who are more familiar with the power knee and they're going to say, but Cosi, it weighs a lot and it's very noisy. Okay. So that's usually kind of the that you hear about the power knee. And here is my response to that. With regards to the weight, yes, it is. Believe it is one of the heaviest knees on the market. But if your suspension and your socket are fitting properly and you are aligned properly, the weight is not going to be a problem. Okay. And I'll even tell you the gal that I worked with at the November conference that I told you about that I went to, she's a petite little thing. She's a cute little petite 5'3" woman. Okay, so she's not very tall. She was zipping up and down with this power knee. She was going up steps, foot over foot without a problem, not having to do this donkey kick business to get up the steps. Okay, so obviously for her, the weight is not a problem. And she's, like I said, she's a small woman. Okay, so the fact that this knee is just working a little bit more efficiently compensates for the extra weight. With regards to the noise, it is a quiet noise. It's a quiet noise. But even my patient this past week, he said, yeah, people can hear me coming, but, compared to the fact that I can walk really comfortably with these knees, I don't care about the noise. That's just kind of how I see it. But so if there's anybody out there who's actually using the power knee, I would love to hear your input and just think about what do you think about the knee? Like I said, I'm still learning about it myself. Marianne says, I'm arguing with my prosthetist. He says I can only get new liners once a year due to Medicare. Oh, Marianne, I got to tell you, I just don't know enough about Medicare. And this is something, guys, that I do have one individual that I really, really, really want her on the show next year. And if she's watching, she knows who I'm talking about because she is an expert on Medicare and these type of questions. So I'm really hoping next year she can come on the show. I say there's got to be a way around that, Marianne. That's all I got to say. Marianne, can you do me a favor? Can you email me that and send me a nudge in the ribs and say, Cosi, find out if there's a way around this for Medicare with the liners. I feel like there should be something you can do about that. So let me see if I can find that out for you. So Emily asks, on a wheelchair, can you switch between a regular leg rest and a residual limb leg rest? I'm supposed to be getting fitted for a new wheelchair, and there might be times where I want to elevate my leg and times where I want to have my leg down when I use a prosthesis. Yes. So, So what she means is, guys, and some of you may have already seen this, right? So in a wheelchair, you have the leg rest where your foot sits in it and it can go up and down, up and down. So Emily, it might be that you just need just the leg rest, the elevating leg rest. And maybe that's all you need. But yes, there is a component where you can take off the traditional leg rest and put the component where it's like a little platform that goes in there. Okay. So depending, yeah, there's definitely an attachment for that. So the physical therapist that is ordering your wheelchair should be able to order that spec for you. All right, next. Let's see what we got. Okay, so Steven says, still having issues getting my socket to fit, lost a lot of the muscles with my AK amputation from the trauma of the motorcycle accident. My PT said I don't have any hamstring muscle causing the flab in my residual limb that's causing the socket fitting issue. My prosthetist keeps making the socket tighter and tighter. Another appointment tomorrow. Steven, can you email me? Email me. It's been a while since you've emailed me, Steven. Can you go ahead and email me? And I might have a suggestion. And I know I sound very mysterious, but go ahead and email me and I might have a suggestion for you. Rupert, I really appreciate that. Thank you very much. Thank you. Let's see. Thank you, Beth. No, man, I am so excited. So excited for you, Beth. Let's see. So everybody's jumping in about the whole liners thing. I know, guys, right? And I think, a lot of it is documentation, a lot of careful documentation about the doctor providing documentation. The physical therapist can provide documentation. The prosthetist can provide documentation to show that it is a medical necessity that you have to replace your liners every 6 months if they are worn out. It's a medical necessity. Okay. Let's see. Patricia says, I had an issue with not being able to get a liner due to Medicare as well. Got my primary care physician to write for a prescription and was able to get it that way. Yeah. So, yeah. Okay. Okay. So let me answer this other part of the question, which, by the way, guys, can I just show you something? I got this in the mail today at my business mail address. Look how pretty that is. One of my viewers sent this to me and it's a real rose. It smells really nice too. Isn't that pretty? So thank you to the person who sent that to me. I really appreciate that. That put a smile on my face this afternoon when I saw that. So thank you. I have it here on my desk to make my desk pretty. Okay, so here's the other part of this question that this viewer sent me. He said, Sorry, I'm trying to find my place where I was. Okay, so I have asked my prosthetist to make sure that my prosthetic leg is the correct height, and I've complained about it to several prosthetists. I've had an independent review for 2 hours on my prosthetic, and everybody keeps on saying it's the correct height. My last prosthetist said it was the correct height, and their software said it was. And when I got home, I just changed it myself, and I go, oh, I don't want to see that. So, guys, this is a big one. That's a big one that I hear from all of my patients, especially my new ones, right? A lot of times, right? My new patients will come into my clinic and they just got their bright, shiny new leg and they'll say, this leg is too short or this leg is too long. And I say, okay, let's try it on, right? And usually when we try on the leg and we put the correct socks on and we put everything on properly and I stand them in the parallel bars and I have them square up and I measure their hips and I measure the shoulder, I do a head to toe measurement to make sure alignment is done properly and it's the correct height. And sometimes I'll even have to put a mirror in front of my patient so that they can visually see that it is in fact the correct height. Okay. Like I said, so for most of my patients, especially those that are new to using a prosthesis, meaning those that have been using a prosthesis for less than a year, okay, it's going to feel off even if they're perfectly even. And that's part of the brain trying to reestablish proprioception. Okay. Big one there. Okay. Now, on occasion, I do have patients that, yeah, the height is off. And at that point, I start asking questions and I'll say, well, did you have less socks on or more socks on when your prosthetist last saw you? Right? Because if you're wearing more or less socks, that's going to change how far up you are or how down you are in the socket and make it seem like it's shorter or longer than what it really is. Does that make sense, guys? Right? So I'll ask them, well, if you were wearing 3 socks at the prosthetist office and today you're wearing 5, right? that might make it feel like it's a little bit too long on one side. Okay. The other part of it is, and this is especially for my above the knee amputees. Okay. When you might be perfectly even when you're standing, right? But when you start walking, if you are not flexing, bending that prosthetic knee, it's going to feel like it's too long. And that's a big culprit. So for this particular individual, right, where his prosthetist has used computerized software to show that his legs are perfectly even, okay, it could be that he is simply not flexing and extending that leg properly, which is going to make it feel like it's too long. Okay. Another thing, okay, if you have muscle weakness, guys, okay, you're going to be compensating. So let me just see if I can stand up and imitate this. This is not my best moment here, okay? Let's say I am a left leg amputee, right? And if I'm walking and I have muscle weakness and I'm lurching over like this, right? When I've put weight on there, right? It's going to feel like my prosthetic leg is too short because I feel like I'm having to lurch over to one side to clear my other leg. Now, it could be that the prosthesis is too short. It could be that you sunk too far down into the prosthesis and we need to put some socks in to elevate you. Yes, that could very well be a problem. But it could also be that you're just weak. You have the muscle weakness, which makes you have to lurch over to one side. Okay. So when I have patients who are getting frustrated because they're like, I've told everybody I feel short or I feel short or I feel too long, these are some of the troubleshooting problems that we go through. Okay. And guys, for me, I believe my patients. When they tell me I feel short or I feel long, I believe you. I just need to find out what is causing your brain to interpret, why do you feel too short? Why do you feel too long? Okay. I don't tell my patients, no, it's all in your head. Well, you're making this up. No. I believe it. Okay. Now, if we've gone through all of that, okay, and I have tested this person this way up and down and twice on Sunday for muscle weakness, and we've gone through the prosthetic alignment and everything is looking good, okay, my absolutely last thing, okay, and this is the last one, and I don't do this very often, is was the patient uneven prior to their amputation? Okay. Was this person uneven prior to the amputation? Meaning, did they have a leg length discrepancy prior to amputation? And guys, every one of us has asymmetry. Every one of us has some sort of leg length discrepancy. If you were to measure me right now, I'd probably have up to even half an inch difference between my legs, probably. Okay. This is the length of my legs. Okay. But if you were somebody that before your amputation, you had a leg length discrepancy, that could be where it's coming from. Okay. This happened to me. This was actually one of my first below the knee amputee patients when I was like, woo, really young therapist, that he was doing amazing. He was coming to PT every time. He was doing his homework assignment and doing all of his home exercise programs. And he was a younger man. And we just couldn't get him off the cane. He could go up and down stairs. He could go over the hurdles, but we're just like, why can't, and I don't know what light bulb went off in his head, but he said, before my amputation, one leg was almost 2 inches shorter than the other. Ding. Ding. And when I mean young man, he was a young man, but he was already in his 40s, meaning he had spent 40 years of his life living with a 2-inch leg length discrepancy. And I don't know how that didn't make it into his medical record, right? So I called the prosthetist in. He thought I was nuts, but he went ahead and humored me. And he said it, not the full 2 inches, but he gave him a 1-inch leg length discrepancy. And it worked. And it worked. And we tried him on it and we just said, okay, he was able to let go of the cane. He was able to start doing all of his activities independently. And it was just like one of those, like, are you kidding me moments? Really? That's all it was. And we did have to check back to say, okay, make sure you're not developing any back problems. Make sure there's no problems that are going to be coming as a result of this. Again, guys, this is one of those like not very often moments, not very often moments. Okay. Yes. Oh my gosh, Paul. Absolutely. Hang on. Let me see. How do I feel about a foot being toed out? 50-50 on that one, Beth. Okay. So, when I'm checking a patient and I say patient square up and I have them stand with their feet close together, I bring the base of support into 4 to 6 inches, and it usually freaks my patients out because they're not used to being that close together, right? Yeah. I'm looking to see if they're toed out. Okay. And if I see that their sound foot is facing forward and their prosthetic foot is out, externally rotated, then I chuckle and I tell my patient, oh, this was a Friday afternoon alignment, right? Yeah, I know all my prosthetist buddies are like, yeah, thanks a lot, Cosi, right? No. So sometimes a prosthetist will set the foot out in a little bit of external rotation to give a patient more support initially, a little bit more stability and balance. But if that's not their normal alignment, like if their sound foot is facing straight forward, then I'll tell the prosthetist, hey, can we set this back to forward? Because I'm going to work with them. So they're going to get used to having both feet facing forward. Okay. Now, if I see that the sound foot is a little bit out and the prosthetic foot is a little bit out, then I say that is the patient's natural alignment. And unless we're having a problem with it, we'll keep it that way. Now, the other thing I look out is if it's externally rotated because the person did not don their prosthesis correctly. That's usually the case for it. But no, if a person does not have a natural toe out, then I ask the prosthetist, hey, please put that back into the normal alignment. Emily says, I really appreciate they use the term residual limb and not stump. I had an aide in the inpatient rehab call it a stump shortly after my surgery. It really bothered me. I still refer to my residual limb as my leg, or I still call it the end of my foot, even though it's not there and there's no foot anymore. And Emily, I'll be very honest with you. Back when I was starting off as a therapist, the word stump was what we were taught. And it's in our medical textbooks. It is an actual medical term and it still exists in our medical textbooks. But obviously I know there's a friend of mine that she's an above the knee amputee and she goes, I hate that word stump. And then on the flip side is I have other patients that look at me and they go, Cosi, it's my stump. Just call it a stump. So, but yeah, I do understand and appreciate that some folks don't like that term. Some people prefer residual limb. Some people call it their little leg. Some people have their own name for it. But yes, yeah. And I just say, guys, if you do have a clinician who uses the word stump, just give them a little bit of grace just because that is medical terminology. And if you just gently correct them and say, hey, can we just call it a residual limb? It just sounds a little bit nicer. Hopefully, if they're a decent human being, they'll accommodate you for that. Let's see. And Paul brings up an excellent point. Paul is an amazing physical therapist. He was the one who taught me. And he says, so the pelvis probably needs to be balanced prior to any prosthetic measurement. Yes. And that's another thing to think about. We've talked about a little bit about that on the show as well. Poor Bob, his pelvis has been fused, so he's not going to really be able to help us much here. But basically, the pelvis is, a couple of bones here. You've got the iliac bone right here, and you have the sacrum, and it's all attached here, okay? And these are not fused together like they are on Bob. These are actually, there's like a little tiny, tiny joint, and it just fits very closely together. So because there's a joint there, that also means that there could be movement, right? So sometimes one of these might be rotated forward or backward, and that might cause a limb to look shorter or longer, okay? And this is where a really good physical therapist can come in some cases manipulate that back into place, depending. But that's a whole nother soapbox for later. Let's see. Ooh, so Beth had that for almost 5 years. Now, Beth, did you have that because you were having problems with balance because of stuff going on? Curious. No, Marianne's going to email me and we're going to see if we can't help Marianne out with the liner problem. Yeah, I know. Steven says, I find that having my feet straight like my natural leg makes it easier to unload the microprocessor knee to bend while in gait in motion. Yeah, especially if you have to load that toe to get that knee to move, then you're absolutely right, Steven. Liz says, I hate that word too. I know. Some people like it, and that's the word that I find like most polarizing. Like some people love using that word and some people are like, I don't want to hear it. I don't want to hear it. Usually it's like the pelvic rotation, Ernest. So like one will rotate, just think of it almost like the Rubik's Cube. You know how you kind of just like rotate the Rubik's Cube this way with the little squares? That's kind of how your pelvis works. I should bring in a Rubik's Cube and show it that way. Okay, so it can rotate just a little bit. We see this a lot, especially in our women who have had babies. So our pelvises were designed that way to accommodate the growth and the labor of a baby, right? So when you go through the labor and delivery process, and some things can get, kind of shifted around and rotated around. And that's where that can happen. Patricia says, my yoga instructor had never dealt with an amputee before and called it my half leg. I have never heard that. She goes, I thought that was cute. That is cute. I've never heard that half leg. That's pretty good. I kind of like that one. Okay. Got it, Ernest? Okay. Guys, I think that's it. I think I answered all the questions for this evening. Yes, MBK stands for microprocessor knee. There you go. I know, right? With all the abbreviations in the medical terminology. There you go. All right, guys. Next week, set the alarms on your phones. And yes, I will be sending a text message out about this one. I am having Click Medical come on the show with Kyle Stepp. Oh my gosh. You are going to love Kyle. He is just an amazing human being. Click Medical has some new toys that just came out. Actually, it's coming out tomorrow. It's a new toy that they're adding to their RevoFit socket system. Cannot wait to share this with you guys. Those of you who are on my email subscription list, then go check your emails because we are going to give you a head start on one of the giveaways. Okay. So if you are signed up for my Cosi Talk subscription, go and check your emails and you're going to see how you can sign up for the giveaway, the free giveaway. If you are not on my email subscription, shame on you, but you can go to my website, scroll down to the bottom of my main page, and you can sign up for the email subscription that way. All right, guys, as always, thank you for letting me be a part of your lives this evening. I will see you next week, same bat time,